Today we're going to talk briefly about the basics of cardiac ultrasound and the basic windows and how to get them. This lecture was initially put together by my just recently departed fellow, Dr. Adorno, but there was some minor changes that needed to be made, so I will re-narrate it. As a thank you to Dr. Adorno for her excellent work with you guys last year, she is this one in the middle, she ended up doing a phenomenal job of teaching you guys, making sure that you guys got a good education as M2s, and hopefully now as M3s you'll continue to get more of an education. Alright, so we're going to jump in first and foremost with talking through what all goes into doing an echo. So the first thing I want to remind you about with point-of-care ultrasound is you have specific focused questions you want to answer, right? Every single study we do is usually a series of binary yes-no questions, and we're trying to answer them to the best of our abilities. So your focused questions are usually ejection fraction, effusion, and equality. So namely, you're looking to see how well the heart is squeezing, which would be ejection fraction. You're looking to see if there is a pericardial effusion, and how large it might be, and whether or not there is any of the sequelae of pericardial effusion. And then finally, you're looking to see if there's any evidence of right ventricular strain. This one gets a little bit tricky because the challenge there is separating out whether it is acute right ventricular strain or chronic right ventricular strain, because there are numerous conditions that can just give you chronic right ventricular strain. So we'll get into sort of the details of the pathology that we're looking at shortly, but we'll start with the basic windows. There are 4 of them. The first 2 views are parasternal views. Parasternal being para next to sternum, sternal sternum, so next to the sternum itself. You have a parasternal long axis view and a parasternal short axis view. We'll talk about both of those as we get into more details. Next up, then you have the apical 4-chambered view, and finally the subxiphoid view. So we'll start off by remembering that when you're looking at the patient's heart, right, the heart usually lies in this orientation in the chest. You'd have a parasternal view. Since this is the sternum here, your probe goes next to the sternum, usually. As a reminder, a lot of patients will have different pathologies that will move the heart up and down and laterally in the chest. So for example, if you have a patient who's got a protuberant abdomen, usually their heart will be pushed up a little higher into the chest. Same way, if you have a patient with hyperinflated lungs due to some sort of lung pathology, normally COPD or asthma, the heart will be sort of shoved down, and all of your views will be more in the lower portion of the chest. However, here, classically, you'll go to the second, third intercostal space, usually just next to the sternum itself, with your probe marker pointed towards patient left hip, and you'll slide around there, looking to see whether or not you can find the heart. This is essentially the view you're looking for. So as a reminder, probe marker is down to the left hip, your probe is right there next to the sternum, usually second, third intercostal space, and you're looking to see this view here. So you'll end up seeing a few things. You'll see left atrium over here, you'd see left ventricle down here, out here is your aortic outflow tract, and then you'd see the right ventricular outflow tract of the right ventricle if we're being less pedantic there. And then finally you'd see the descending aorta. The descending aorta becomes important, and we'll point that out briefly, because it helps you separate a pericardial and a pleural effusion. Next up, you'd look to see whether the mitral valve is, where the mitral valve is, should be between the left atrium and the left ventricle. And then you'd also see the aortic valve. As a reminder, in general point-of-care ultrasound, we don't typically look for valvular pathology, but we will at least identify the anatomy. This is what your view looks like with a normal parasternal long axis view. You can see here that your mitral valve is moving nicely. You can see that the aorta is still there. There is the pericardium right here, this bright white line. You can see that there is no, and the other thing you can look for is to compare these 3 structures, the left atrium, the aortic outflow tract, and the right ventricle, to look and see if those are similarly sized or not. If any of them is enlarged, that could be abnormal. So for the next view, we're going to go ahead and rotate our view 90 degrees with the probe marker pointed down towards the right hip. So when you find the one view, the second view follows pretty much immediately. As a reminder, here you're going to slice it in this plane. So it would stand to reason by slicing it in that particular plane across the short axis of the heart, you'd see this view, where here you'll see the left ventricle with a papillary muscle right there, and then you'd see the right ventricle up here as well. And when you're watching it, this is what the heart will look like. You'll see nice crisp endocardial border there, myocardium there, right ventricle there, technically the right ventricular outflow tract you can tell because right there is your pulmonic valve. And you're able to see sort of as the heart is beating, you're looking to see if in particular this view is great to look if there is any evidence of a depressed ejection fraction, or if you're being particularly fancy like one of my fellows should be at this point, looking for regional wall motion abnormalities. Next up, we're going to move on. If you're trying to do an apical four-chambered view, this is the one that classically a lot of folks struggle with. The classic location to look for this is looking from the apex of the heart, looking up at the entire heart. So, in a man, you'd basically go right under the nipple with the probe marker pointed towards patient right, and this is the way the probe would be oriented. And if the probe is oriented in this orientation, it would make sense that the heart would just be flipped on the screen. So you would end up seeing on the anatomy, left atrium down here, left ventricle there, right atrium here, right ventricle there. And again, you'd see mitral, and then for the first time, you're seeing the tricuspid valve here. This is what a normal apical four-chambered view looks like. Again, as a reminder, left ventricle, left atrium, right ventricle. Okay. The next view, after all of this, is the subxiphoid view. In this view, in particular, most useful typically for looking for a pericardial effusion, you're putting the probe underneath the xiphoid process, hence subxiphoid. The xiphoid process at the bottom of the sternum, usually right around here. So your probe marker will end up here with the probe looking up and your probe marker to patient right. So that would give you a view sort of like this, and you'd end up going through the liver to get to that view. So again, everything's going to be flipped as what you see it. So here's that little schematic again. You'll see liver up here. You'd see right ventricle closest to the anterior chest, right atrium here, and then you'd see left ventricle and left atrium here. And again, you can see mitral and tricuspid valves. And then on the subxiphoid, this is sort of the view you're expecting. You can see that nice bright pericardium. You can see here that the heart is beating, albeit this one is beating poorly. If you guys have any questions about the basics of this is my email. Stay tuned for the next video where we're going to talk through the actual pathology as well.